Hello, good afternoon, everyone.
Good
And
afternoon.
I welcome you all for this webinar on continuing nursing education, which is mainly for improving nurses' knowledge. And so we are providing an educational platform for nurses. So today also we have certain eminent speakers with us who will be discussing a few topics on neonatology, like uh, arterial blood gas analysis, as well as quality improvement care in the neonatal nursing unit. And we have already sent a YouTube link to all the viewers, so they all can view this program live on YouTube. And if there are any questions from you, we'll surely take those questions and you can put them in chat box, in the YouTube chat box. So please make use of that chat box to ask any doubts or questions related to the program. So without wasting much time, I invite Dr. Jaisal Seth, ma'am, to introduce our expert today and begin the session.
Good evening. Basically, we wish all of you a very, very happy nursing week and belated Nursing International Day. We every time we basically think about how do we keep our patients safe. And we always, when we go to, if we travel by bus or a train or aeroplane, we never ask the name of a, conductor or a bus driver or a, pilot. We just board because, we think that traveling through these vehicles is safe. We don't have to know the name. But same thing is not actually true in the medical industry. We always have to ask, who is the doctor, who is the nurse, which is hospital we have to go to before you choose the place to get treated. So that is because we lack standardization, and that's why we don't have safety and quality in many places. So today, the talk is going to be very interesting because two topics, one which we do in and out every day, that is ABG in the NICU, and we all are going to learn how to interpret it and very simple way, not very difficult way. And second talk is also a very nice talk, very close to my heart. What we can do to improve the quality and then bring the safety to our patients, so that it doesn't matter where the patient is getting treated, but all of us get the safe treatment everywhere. So with that, I would like to actually introduce my very dear friend, Dr. Kedar. Dr. Kedar is an associate professor in GMC Medical College, Aurangabad. He is a mentor. He is a simulation facilitator. He is the national faculty for multiple programs in the neonatology, and his own unit is one of excellent unit actually to have the experience of all this quality safety. He is also a national faculty for the NEST program, which is a simulation based program for the neonatal intensive care training. And he is a chief neonatologist in Deogiri Children's Hospital, Aurangabad. So without again wasting more time, I like to invite Dr. Ketur to introduce another two speakers.
Thank you, Jason. Thank you for the kind introduction. So today we have two very important and very day-to-day topics which we are going to discuss. I will just share my screen here. And two eminent faculties who are going to discuss these two talks. So first, I invite Dr. Atul Londe, who for his talk on ABG, Made Easy. So he has done fellowship in neonatology from GMC Aurangabad and is currently working in the same college as assistant professor in neonatology since last 6 years. And he has many national and international publications in reputed journal. He is also a trainer for basic NRP and FBNC, and he is a co-author of just a couple of days back an article on KMC quality improvement, which was published in which is BMJ South Asia edition, which is going to actually get published very soon. But his article has already been accepted for publications in that. So with this short introduction, I introduce Dr. Atul for his talk on ABG.
Thank you, sir. Before starting our session, I like to wish all our nurses a very happy Nurses Week and belated Happy Nursing Day, which was yesterday. And I really believe that nurses are backbones of NICU. They are important wheels of our healthcare system. Also, I would like to thank you to NNF for giving me this opportunity for presenting this talk. So we'll start today. The topic is ABG made easy for nurses. This is the institute where I work since last almost 6-7 years. So we'll go through these headings. That is, what is ABG, why ABG is required, how to collect ABG sample, procedure, how to send a sample, what are the precautions before sending a sample or before running a sample, and lastly, we'll see basic steps to analyze the ABG with few examples. We do ABG day in, day out. This is a ABG strip which is seen on the screen. And you can see there are many parameters. There is a temperature shown in first and third line. This ABG is run at 37 degrees of temperature. And there are other values that pH, PCO2, PO2, and there are many more values seen on the strip. The strip is different for each machine. Few of the machines are advanced. They are also measuring the carboxyhemoglobin and methemoglobin also. But this is we need these basic things to interpret our ABG. So what is an ABG? ABG means it is arterial blood gas. We measure the partial pressure of carbon dioxide and partial pressure of oxygen dissolved in the blood. But not all gases which are available, which are present in the blood are measured, like nitrogen is not measured. ABG is required for evaluation of respiratory function, that's both oxygenation and ventilation. Also, it is important for measuring the acid-base balance or checking L-base balance in critically ill babies. In true sense, it is a reflection of our milieu interior. Also, it is helpful to characterize if the disorder is metabolic or respiratory, what is the severity, and whether it is compensated or not compensated. When to do ABGs? ABGs are done in severe respiratory metabolic disorders, in babies who are on respiratory support and oxygen therapy, on ventilator support, to evaluate the effect of the treatment, in babies with shock, severe sepsis, in renal failure, and in cases of inborn errors of metabolism. From where to take these ABGs? ABGs can be taken from arterial sites like radial artery, umbilical artery. Brachial artery is less preferred because of its proximity to median nerve. Venous sites are good option for pH and PCO2, but not for PO2. As you can see in the table, that there is a difference of almost 0.02 in pH. So they are good for pH and PCO2. Capillary blood samples are a good alternative for arterial samples. They are specifically used as a word as arterialized capillary samples. Definitely we need different machines to read this, but advantages being the small sample, being non-invasive. We can take multiple samples with through capillaries. And muons, many times the heel is used for arterialized capillary samples, and the heel is pre-warmed, and the heparinized capillary is used for taking sample. The table shows there is not much difference between pH, PCO2, and PO2 in arterialized capillary samples and arterial samples. So commonly which is taken for artery, but arterialized capillary samples are also a good option for doing ABG. While collecting ABG, being an invasive procedure, hand asepsis and procedure asepsis is must. Ideal artery, we have seen it's radial or umbilical artery. If we are taking sample from umbilical artery, we have to assure that there should be free flow of blood, and we have to take 3 to 4 times of dead space volume before sample is taken. And after taking a sample, we have to push slowly the sample which we have taken. Care should be taken that we should not allow any air bubble in the syringe, otherwise the values of PCO2 and PO2 will be altered. What is Allen test? It is a modified Allen test is done to check the collateral circulation of the palm. The radial and ulnar artery forms deep and superficial palmar arches. If we're going to prick the radial artery, we have to confirm that the collateral circulation from ulnar is maintained through it. Otherwise, if the collateral circulation is not available or not there with ulnar artery, then there will be a high risk of thrombosis and necrosis or gangrene of the hand. So before doing ABG or before pricking radial artery, we have to do Allen test. So let us see how to do Allen test through this video. So if there is no collateral circulation, we should not prick that radial artery. We should assort for other limb, or we should go for other artery, that is maybe the umbilical artery or brachial artery in such cases. Let's see the video for sample collection. Sorry. So during this procedure, the baby was given to milk swab to relieve from the pain. So we have to take this sepsis and proper care, pain management during this procedure, because arterial puncture is quite painful. So we have to use a small volume of heparin for just lubricating syringe and the plunger. If volume is more, dissolve oxygen and heparin syringe may increase the PO2. So use heparin of lesser strength, that is 1000 units per ml instead of 5000 units, or one can use heparin block solution that contains 20 units per ml also. It is better to use glass syringes as these plastic syringes are permeable to air, but nowadays it's difficult to get glass syringes, so you can use plastic syringes, but the sample should be sent immediately within it's processed immediately, preferably within 30 minutes, as blood is living medium and cells consume oxygen and produce carbon dioxide. If for some reason we are not able to send the sample immediately, the sample should be stored in the refrigerator. Slush of ice should be used for storing samples till processing, not the cubes. So till this time, we have seen what is an ABG, what are the important components of ABG, and what are the indications of ABG, when to take ABG, what are the sites, and what is the procedures along with Allen test for ABG. Now we'll see what are the basic steps for interpreting ABG. While interpreting ABG, machines measure only pH, PCO2, and PO2. Rest other parameters are derived from software-based algorithm. These values, we can also derive these values from a nomogram called Sigurd-Andersen nomogram. This is Sigurd-Andersen nomogram. It shows there are first is total CO2, bicarb, then third is base excess, pH, and CO2. If we know any two values, pH and PCO2, or pH or total bicarb, we can calculate bicarb and base excess from the Sigurd-Andersen nomogram. The same machine does the same. It measures only three things: pH, PCO2, and PO2. Rest all are calculated findings. ABG value should be interpreted with clinical history. That is, we need medical history. We need a thorough clinical examination before interpreting ABG. We need respiratory support details, on which the support baby is on CPAP or ventilator, or how much pressure he is receiving, how much MAP is baby is getting, what is the FiO2 baby is getting, and also previous ABGs to see whether it's improvement or not improvement, deterioration. We need previous ABGs. Also, we need the hemoglobin content of a baby before commenting on ABG, because if baby's hemoglobin is low and the PO2 is good, still baby's oxygen carrying capacity will be lower. So we need hemoglobin. This much finding we need before interpreting ABGs. So these are the basic 6 steps for interpreting ABG. We'll go step by step with few examples also. So first we'll see what are the normal neonatal ABG values. The pH is in the range of 7.35 to 7.44. PO2 50 to 80 millimeters of mercury. PCO2 35 to 45 millimeters of mercury. Bicarbonates 20 to 24 millicurrents per liter, and base excess -3 to +1. We'll see each one by one. There are few terminologies used while interpreting ABG. One is acidosis. It's pH less than 7.35 is termed as acidosis. pH more than 7.44 as alkalosis. Hypoxemia if PO2 less than 50. Hyperoxemia if PO2 more than 80. Hypercapnia if PO2 more than 45, and hypocapnia if PCO2 less than 35. So first question is, what is my pH? So, as I told before, the pH is in the range of 7.35 to 7.44. pH less than 7.35 is termed as acidosis. More than 7.44 is termed as alkalosis. The pH gives an idea of primary acid-base disturbance. So sometimes pH is in the normal zone, that is in between 7.35 to 44. Still, there may be acidosis or alkalosis, like in a compensated reports. Still, we have to complete all ABG. We have to come to all steps. That we have to see a bicarbonate, PCO2, and after that we have to interpret it whether ABG is normal or abnormal. In compensated ABGs, the pH lies between 7.35 to 7.44. In that cases, we have to consider pH 7.4 as a mean, and less than, if pH is less than 7.40, even if it's 7.38, so we will consider that the pH is on acidotic side. If pH is more than 7.40, in between, still in between range, if that is pH is 7.42, we'll consider the pH is on alkalotic side. It may not be pure acidosis alkalosis, but on alkalotic side for the sake of interpretation. The last line is Henderson-Hasselbalch equation. It is pH is directly proportional to the bicarbonates and pH is inversely proportional to the PCO. So pH is directly proportional to bicarb, means bicarb indicates metabolic component. CO2 indicates respiratory component. So pH is directly proportional to the bicarb, that is bicarb falls, pH falls. And bicarb rises, pH rises. and pH is inversely proportional to PCO2. If PCO2 rises, pH falls. PCO2 falls, pH rises. So this basic idea we should have before interpreting ABG. So once again, the pH is directly proportional to the bicarb and pH is inversely proportional to the PCO2. So we go to next step. So next step, what is my primary disorder? So PCO2 alterations means respiratory problem. So pH less than 7.35 and PCO2 more than 45, it is respiratory acidosis. If pH is less than 7.4, more than 7.45 and PCO2 less than 35, it is respiratory alkalosis. Similarly, the bicarb indicates it is a metabolic problem. So if pH is less than 7.35 and bicarb also low, it is less than 20, it is metabolic acidosis. So pH is low, bicarb is low, metabolic acidosis. pH is more than 7.45 and bicarb more than 24. pH is raised, pH is increased, bicarb increased, it is metabolic acidosis. So basic things, PCO2 indicates respiratory problem, bicarb indicates metabolic problem. PCO2 is inversely proportional to pH and bicarb are directly proportional to pH. These four things we have to remember before going ahead. So in the simple disorder, what is simple and mixed will come later, but remember this slide. In simple disorders, in metabolic acidosis, pH falls, bicarb falls, and for compensation, PCO2 falls. In metabolic alkalosis, as it is alkalosis, pH rises, pH goes beyond 7.4544, bicarb increases, and in compensation, PCO2 also increases. In respiratory problems, as it is, the pH has inverse relationship or inverse relationship with PCO2. In respiratory acidosis, as it is acidosis, pH falls, but PCO2 rises, and in compensation, bicarb rises. And respiratory alkalosis, pH rises and PCO2 falls, and in compensation, bicarb also falls. So we take a few examples. We'll see the pH is 7.19, PCO 25, and bicarb at 12. We interpret this. So first is pH is less than 7.35 means it is acidosis. So bicarb are decreased. So pH is decreased, bicarb is reduced. So it is metabolic acidosis. See another example. This here pH is 7.59, PCO2 is 42, and bicarb are 30. So pH is more than 7.44 means it's alkalosis. The bicarb are more than 24, so it is metabolic alkalosis. So pH is increased, bicarb are increased, so it is metabolic alkalosis. Third example, pH is 7.22, PCO2 50, bicarb 25. So pH is less than 7.35, it is acidosis. But here PCO2 is increased, more than 45, so it is respiratory acidosis. And last example, pH 7.52, more than 7.45, alkalosis, and PCO2 has washed out, so it is respiratory alkalosis. So first see what is my pH. Is pH the acidotic zone or as alkalotic zone? Then what is leading to the reduced pH or increased pH? Is it the bicarbonate leading to reduced pH or increased pH, or is it the PCO2 leading to reduced or increased pH? We give an idea where is the problem. Is it a primary metabolic problem or a primary respiratory problem? Okay. So next step will be is my disorder is compensated, partially compensated, or uncompensated? In compensated disorders or disturbances, the pH will lie in the range that is 7.35 to 7.44. In partially compensated in disturbances, the pH will be near, maybe pH will be from 7.35 to 7.34 to 7.31 or 30, or 7.45 to maybe 7.50 in partially compensated. And in uncompensated disturbances, the pH will be way away from the range of the normality, that is 7.35 to 7.45. So depending upon the level of pH and compensation, we have to see whether my disturbance is compensated, partially compensated, uncompensated. So now how to calculate how this compensation occurs? The compensation occurs through an organ which is not primarily involved. That means if it is a respiratory problem, the compensation is by metabolic disorder, metabolic way. If the problem is metabolic, then the problem the compensation is by respiratory. Just remember, the body tries to create an opposite disorder. If for its metabolic acidosis, body tries to create a respiratory alkalosis for compensation. So same here, the respiratory acidosis is compensated by the kidneys, and metabolic acidosis alkalosis are compensated by increasing or decreasing respiratory secretion of the carbon dioxide respectively. So what is the level of compensation? These are the four formulas which are used to calculate the level of compensation. That is, in metabolic acidosis, we have to calculate the expected PCO2. This is the formula 1.5 into bicarb plus 8 plus minus 2. Whereas alkalosis, we have to calculate expected PCO2 is 0.10 into bicarb plus 9. In acute respiratory acidosis, for each 10 millimeter increase in PCO2, bicarb rises by 1. And in chronic respiratory acidosis, for each 10 mm increase in PCO2, bicarb rises by 3. And similarly, in respiratory alkalosis, for acute respiratory alkalosis, for each 10 mm fall in PCO2, the bicarb falls by 2. And in chronic respiratory alkalosis, for 10 mm decrease in PCO2, bicarb falls by 4. So we have to remember these four formulas to calculate the level of compensation. So we will take one or two examples of compensation. The first example, the pH is 7.19, so it is less than 7.35, it's acidosis. So pH is decreased, bicarb are reduced, so it is metabolic acidosis. The expected PCO2 will be 1.5 into 118 plus 8, so it comes around 26 plus minus 2. So the PCO2 is not compensated till. So because of this, my pH is in the uncompensated zone. So once PCO2 will be near to 26, so definitely pH will raise and go nearby to 7.35. So similarly, we have to calculate the compensation of each and every disorder and manage accordingly. Next step is, what is base excess? What base excess means? It is the difference between observed whole blood buffer base of the sample and expected normal whole blood buffer. That is, the blood buffers are formed by the proteins, carbonic acid, and phosphates. So it is normal value is 40 to 49, and what is difference between actual and expected is called base excess. The normal range is -3 to +1. Sorry. And the base excess, if it is the value is negative, it is called base deficit. If the value is positive, it is called base excess. So if the values are -10 or beyond +10, then it shows the clinically significant acid-base imbalance. So it is an indicator of metabolic component of acid-base disturbance. So whenever there is base excess of more than -3 or +1, so there is metabolic component is creeping in. So base excess means how much base or acid is required to maintain the pH of 7.4. In simple means. The last step is my disorder is simple or mixed? See the first example. Its pH is 7.09, PCO2 is 49, and bicarb is 18. The pH is 7.09 means pH is less than 7.35, it is acidosis. Bicarb is 18, it is also decreased. So it is metabolic acidosis. But can you see the level of pH fall is not correlating with PCO2, or even the level of increased PCO2 is not correlating with pH. So it is there is exaggerated pull of pH. So it is a mixed disorder. So in first case, it is a mixed acidosis. It is both. It is respiratory as well as metabolic acidosis. In babies who are in respiratory insufficient, that they develop metabolic acidosis, and after some time they lose their ability to compensate, and mixed respiratory and metabolic acidosis ensues. So whenever there is exaggerated pull of pH, as the pH is the fall of pH or rise of pH is not correlating with either PCO2 or bicarbonate, then suspect there is a mixed disorder. Why we have to differentiate between simple and mixed disorder? Because depending on the simple mixed disorders, the management varies. So we have to see whether the disorder is simple or mixed disorder. And depending upon these 5 steps, we have to identify the disorder and treat the cause, not the just disturbance. That we have to identify: is it a metabolic disorder, respiratory disorder, acidosis, alkalosis, with compensated, partially compensated, uncompensated, simple, or mixed, and treat accordingly. Here we have finished the acid-base disturbance part. We'll go ahead with oxygenation part. The oxygenation is shown on the ABG strip by only PaO2. Normal value of PaO2 in babies, neonates is 50 to 80 millimeters of mercury. But we don't know if we want to interpret just based on PaO2. We don't know how much effort baby is receiving. Suppose if a baby is PaO2 is 80 and baby is on 20% oxygen, that is room air, and another baby is PaO2 is 80 and the baby is on 100% oxygen. Definitely, the 100% the baby who is on 100% oxygen is more sicker than baby is on room air, because the PaO2 is, even if baby PaO2 is 80, it doesn't mean that baby is in normoxemic zone. So we have to see, we have to interpret PaO2 in consideration with what FiO2 baby is taking. If baby is on ventilator, what MAP is baby taking. Also, the PaO2 values are better interpreted from indwelling catheters, that is umbilical catheters, in quiet and resting conditions, because a crying, irritable baby will change PaO2 value. As far as possible, try to take samples from indwelling catheters when we want to interpret specific PaO2. Also, the PaO2 values vary considerably in sick neonates throughout day. This is the first parameter we have to see apart from PaO2. That is, it is alveolar arterial oxygen gradient. That is, it is simple. We inhale oxygen reaches to our lungs, that is alveoli, and how much oxygen which we are inhaled is passing to arteries. This gradient shows that. Okay, it is that how much percentage, how much amount of oxygen is crossing the alveoli and reaching to the arteries. So the formula is the partial pressure of alveolar oxygen, that A capital means it is alveolar oxygen, and small a means it is arterial oxygen. The formula for calculation of PA, that is alveolar partial pressure, is FiO2 into 713 minus PCO2 divided by 0.8. So ADO2 is more concise than just FiO2 or PaO2. It takes into consideration FiO2 and PaCO2 also. So ADO2 is increased when there is block in diffusion. There is block in diffusion from alveolar to capillary, when there is ventilation perfusion mismatch, and when there is fixed right to left shunts. So how do we interpret? If value is between 100 to 200, it is considered mild to moderate disease. 200, 400, moderate severe disease. More than 250, ventilation. More than 600 value is a ECMO indication. Second parameter being oxygenation index. It is used to assess the severity of hypoxic respiratory failure. OI is used as marker for clinical management and for initiating therapies like inhaled nitric oxide for PPHR. Sometimes in clinical trials, it is used for deciding the need of surfactant or surfactant, surfactant use in like in case of PPHN or in case of Macon-Asper syndrome. OI is an important predictive marker for neonatal outcomes, including neonatal mortality. If OI is more than 25, there is a risk 50 to 60% risk of mortality, and if OI is more than 40, then it is almost 80 to 90% risk of mortality. More is the OI, sicker is the sicker of the lungs. So, what is the formula? It is the MAP, that is mean air pressure into FiO2 divided by PaO2. So, if OI is less than 15, it is mild hypoxic respiratory failure. 60 to 25, moderate. 26 to 40, severe hypoxic respiratory failure. And if it is more than 40, it is being an ECMO indication.
Doctor, 5 minutes to 9.
Yes, ma'am. Yes. Third index is the ratio between the alveolar partial pressure of alveolar arterial oxygen versus partial pressure of alveolar oxygen. So here it is different from ADO2 that it is a ratio. In ADO2, we subtract there, and here it's a ratio. So being a ratio, it does not change with FiO2. In normal pneumos, the value is near 1, that is 0.7 to 0.9. In severe cases, the values may fall below 0.7. So this is the third parameter. And one more parameter is respiratory index. That is, it is the ratio of ADO2 versus PaO2. If it is more than 5, it is considered as referent hypoxemia. So these are 4 parameters which are used for oxygenation. One is ADO2, second is oxygenation index. These two are more important than these rest 2 ratios. So before I finish my presentation, I will take a few messages. One, the ABG is true reflection of milieu interior. So being an invasive procedure, we have to follow strict asepsis while collecting ABG. Use minimum heparin just to flush out the syringe. Otherwise, the reports of pH and rest PO2, PCO2 will be altered. Try to collect the samples after 30 minutes of interchanges to see what effect interchanges have done in my ABGs. There should not be no air. There should not be any air bubble in the syringe. Otherwise, the PO2 values may go up to 150 because of that air bubble. We need immediate processing of the sample, that is as fast as within 30 minutes. If not possible, store the sample in the fridge before you process. And ABG should be interpreted in accordance with the condition of baby, not individually. Thank you.
Thank you, Atul, for a nice lucid presentation on ABG. So some practical points, what he has highlighted is how to collect the samples. So asepsis and pain control is very essential in these babies. Arterial prick is one of the most painful stimulus which we give to newborn. Flushing the syringe with heparin, that is also important. After you take the sample, how to store it in the refrigerator with the ice slush is also a very, very important step. Otherwise, your parameters will get altered. And flushing the line after you take the sample from arterial line is also very, very important. One of the most important thing is if the situation allows, it is better to do suctioning and wait for a few minutes and then send ABG. Otherwise, some secretions in the tube might affect your CO2s and pH. So that is one important aspect we must not forget. And thank you, Atul, for your nice presentation. So you can stop your screen share now.
Yes.
So now we have next presentation. So I have the pleasure of introducing you Dr. Pratima Anand, who is DM Neonatology from AIIMS. He is a faculty at VMC and Safdarjung Hospital, Delhi. And to her credit, she has more than 35 publications in national and international journals. And her special areas of interest are neonatal intensive care, sepsis, and neonatal research. And she has worked as co-investigator in immediate KMC studies, follow-up of immediate KMC study, neonatal sepsis biology, and the role of biomarkers in neonatal sepsis. She is also NNF Delhi State Coordinator for Advanced and Basic NRP and National Trainer in Pediatric Advanced Life Support and Basic Life Support. She is also a National Trainer in Facility-Based Newborn Care and National Neonatal Trainer in Preterm Care Package AIIMS. So she is going to discuss an important topic regarding quality improvement. So I request Dr. Pratima to start her presentation.
Thank you, sir. To begin with, I would like to thank the organizers for giving me this opportunity. And as Dr. Jaiswal said in the beginning, the topic is close to my heart, the role of nurses in hospital quality improvement and hospital care services. So today's topic, I would like to take you through the steps of quality improvement and along with that, the role of our nursing colleagues. And it is very aptly timed in the International Nurses Day and the International Nurses Week. So we cannot deny, and all of us who work in different setups cannot deny the power of frontline workers. And famous authors have already said that as direct caregivers, the nurses are the ones who have a huge impact on the care which the patients receive. And I'm just quoting two of them, that those who actually provide direct services on floor and in front line are in excellent position to identify the challenges, the need for change in the services, and how to actually bring about the change. So that makes our frontline workers, including the residents and the nursing staffs, the most powerful to bring about the change. And just to give them statistics and facts, nurses represent about 1/3 of the hospital employees, and it's a sizable segment. And they do have thorough understanding of the resources available, more than the doctors sometimes. And they are uniquely experienced in their initiatives for clinical transformation, patient safety, satisfaction. They actually know the intrinsics and the intricacies of the sufferings of the patients, and the opinions which the patients have and the patients' attendants have, because they are the ones who are mostly dealing with the directly dealing with them. So it is a critical role. The nurse has a critical role in healthcare in general. We'll come to the quality improvement part. But in general, they are a bridge. We all know that they are a bridge between the policymakers, the competitive authorities, the physicians, the doctors, and the paramedical staff, along with the resources and the stock, the hospital stock, which is there. So she is the link, the critical link between all the things, and most of the things are in her knowledge. So with this background about the nursing colleagues and their role in healthcare in general, I would start with the concept of quality improvement and how the nurses have actually become the forefront runners for this, bringing about the improvement. So the quality improvement actually started in 60s with three popular sociologists, Stewart's and Deming being two of them. And Stewart's charts are the control charts, which actually he brought about the statistical quality controls. And they actually were, they brought about the role of sociology, the importance of teamwork, how the changes can happen, and behavior and sociology in the improvements. So these two and three people together, they started this revolution sort of thing in 1960s. And basically the concept which is behind the quality improvement is Donabedian triad. And again, the Donabedian, the person, Donabedian was a physician in Michigan. And he actually conceptualized that for information about healthcare, to bring about improvement in the healthcare, the information actually has to be in three main domains, which is the structure, the funds, the staff, and the equipment which a hospital has, the guidelines and the protocols which they have, the written ones, process, which is how the actions and the actual procedures are carried out within this infrastructure, and ultimately leading to a outcome, the effect which these things have on the outcomes in the healthcare. The principles of quality, as we all are aware, it actually has a mnemonic of STEEP. It should be safe, should be timely, should be effective, efficient, and patient-centered. So we see and we can imagine that nurses and doctors both are at the center of all these things for providing a safe care. Timeliness means the injection, if it is written, the prescription is written, it should be provided at the time which is mentioned there, or at whatever the precise time at which the treatment is needed. Effectiveness, efficiency. Efficiency is actually reduction of wastage. And none of us can deny the fact that whatever care we provide, we should actually avoid wastage, be it in terms of manpower use, equipment use, any disposable use. So efficient care. Efficiency means reduction of wastage. Effectiveness is whatever we are giving the care, it should be actually reaching to the patient, and it should be effective in its outcomes. And of course, it should be patient-centric. So these are the principles of quality. And what do? We do a stepwise procedure in which we actually plan, do, study, and act. We start with an aim. I will come to the steps in detail. We start with an aim, which should be SMART aim. And then we know, we measure what we are actually trying to do, trying to reach a goal. We collect some data and measure what are the changes we are doing. And then after looking at those changes, we can actually either adopt or abandon that change and make it a policy and intervene in the hospital care systems. So to bring about a change, we have to have a knowledge of the existing resources, and our nursing colleagues are the best, as I told you, that about the infrastructure, the drugs and the materials which we have, the information and the databases which we have to look at what is actually being done in the healthcare system now, how is it being done, and what changes can be brought both in the content of the care as well as the procedure or the method by which it is being done, and have to measure the outcomes in terms of the either the delivery which is there, the hospital services delivery, outcomes of the patients, or the change in the health behavior like hand washing, counseling. So these are all the things which we can measure. So whenever we design a quality improvement project, there are 6 or 7 key steps. We need to identify a problem. The hospitals and the healthcare have a lot of multi-pronged problems which are occurring. But to bring about a change, we need to have a specific and a selected problem. We should prioritize a problem, like which is the priority which we should be done, which is actually easier to be done. We should not be choosing a bigger problem which is actually in the hands of a lot of people, like reduction of say maternal anemia or reduction of low birth weight babies. In those cases, the problem is multi-pronged, and it starts right away from the adolescent to the newborn period, to the perinatal period. So selecting such a wide and a multi-pronged problem may not be actually a very smart aim and a smart goal. So selection of the problem which is contextual, which is important to your own hospital, which is actually doable in your setup, that should be the main and priority. That should be the priority in clinical care. Like it should bring about a change. You should visualize that it will bring about a change. So selection of a problem. And none other than the nursing colleagues can actually select, or they can be the whistleblowers, like what is happening, whether wastage of resources is occurring, whether hand washing is not happening properly, whether sepsis is increased in the unit. So all these things, the first whistleblowers are actually our nursing colleagues, residents, and the on-floor workers or frontline workers who are there. After that, we have to build upon a team. We have to select an aim, proper aim. We have to analyze the root cause, then measure the outcomes, and then measure the desired changes which have resulted in our desired outcomes. So we have to identify the change which has brought about that desired outcome. Then we actually adopt that change and test in the further cycles, itinerary cycles, and then we adopt it as a policy in the unit. So these are the 6 or 7 key steps in designing a QI project. And I will take you through that how the role of nurse actually comes in each of the problem. So as I told, selection of a problem actually begins when a worker or when a healthcare provider observes that it begins with an informal observation that something is happening, like I feel that the babies are dying a lot in the last 15 days, or I think the babies are becoming hypothermic more in the last 1 week. I have noticed that the trolleys are not being shifted rapidly from from the emergency to the NICU area, or from the delivery room to the NICU area. So these are the informal observations which are done by the frontline workers, and then we collect our data based on that, and then we prioritize, like what is the problem, where is the problem happening. So at this step also, you see there is a role of a nurse and there is a role of the frontline workers who can bring about this problem to the policy makers. So identification of the problem, which is clinically important and amenable. Newborn specific example can be whether the mothers are doing KMC or not. Sister may observe that last month the KMC was being done very well, the mothers were coming, but this month I have observed that mothers are not doing KMC, or the express breast milk is not there. So the problem identification again actually becomes the core thing, or the first thing, the preliminary thing for the project to begin. After a problem is identified, we have to have a team. And I cannot emphasize the role of nurse and the nurse educator, the nursing superintendent, all the prongs of the nursing colleagues who have to be a part of the team to bring about the change. We are there, the residents, the doctors are there, but it ultimately has to be a team, and the core component actually becomes our nursing colleagues. And there should be a multidisciplinary composition of the team, 5 to 7 members, and it should include the leadership, the system leadership, the clinical expertise, or the faculty who is taking the rounds, and the champions who are mostly again the residents and the nurses. Once we have identified the team, now we have to make an aim statement. Aim statement, we know the problem. Why to make an aim statement when we know that we have to increase the KMC duration, we have to increase the breastfeeding in our unit? Then why do we need an aim statement? We need an aim statement because we need to have a specific data or a specific goal to reduce or to increase the problem. So it should be specific and simple. It should be measurable, achievable, relevant, and timeline. And it is mnemonic as SMART aim. So we need a SMART aim because if we keep the goal very broad, like if we just say that we want to increase KMC, the project would not be successful. We have to make it specific and have a timeline, particular timeline. Suppose the duration of KMC in your unit was just 2 hours in a mother. Now make it specific that from 2 hours, you want to increase the KMC to 8 hours over a period of 4 weeks. So that makes the team very motivated that we have a measurable outcome here. And in 4 weeks, we want to increase the KMC rates to such and such extent. So that seems doable. And the team is actually motivated if you give them a SMART aim rather than giving a big goal. Nobody will follow what is happening if you just want to say that we want to just increase the rates of KMC. And again, the teamwork and the role of doctors and nurses comes here because unlike the research which is statistically done and the randomized trials and the proper statistical research which is done, the quality improvement or the quality studies, they actually are timelined. They are done over a period of 6 to 8 weeks. No doubt they have to be sustained, but they are done over a period of 6 to 8 weeks or 12 weeks maximum. They are actually, the changes are brought about in multiple short test cycles. So the team is able to see a result or the change in data in a short time, in 2 weeks, 3 weeks. And it does not require too much of statistical analysis. A run chart or a simple bar diagram would show you that what was the change that has occurred over the past 3 or 4 weeks. So these are the key differences I want to highlight between the quality improvement studies compared to the randomized trials and the research which is there. So in quality improvement, what we do is we already know that this intervention works. We are not discovering anything new. We know that KMC works. We know that breastfeeding works. We know that hand hygiene works. But whether it is being done in our unit, how to actually implement this evidence-based guideline and how to bring about the change. So it is actually very satisfying, and I'll just show you real-time examples also. So once we have selected a problem, identified a team, identified an aim, we want to now measure the data and see the outcomes. The outcomes actually can be process outcomes, and they can be outcome measures of the effect of the process which have taken. Like suppose we want to reduce the sepsis in unit. So the process would be, we can choose one process. There can be many processes which can lead to reduction in infection, but we have, for a project, we choose one process outcome, which is process measure, which is washing hands. And then we measure the outcome. This is called outcome measures, which is reduction in infection. So we see that the data collection, the records, the registers, the continuity of care, all these things are actually available with whom? With our nursing colleagues. They are the ones who can actually implement checklists. They can implement the adherence to hand hygiene, the steps of hand hygiene. We had carried out many QIs during my training and also at Safdarjung. And we have actually given most of the tasks of checking that who is doing the steps of hand hygiene to the nursing colleagues. The monitoring sheets, they are all with the nursing colleagues. So here again, the role of measures, processes and outcome measures, the core and the team members are actually our nursing colleagues, and we see that the records and the checklists, the monitoring sheets are with them. So after we collect root cause analysis and we collect the baseline data, even for root cause analysis and even for analyzing the problem statement, data can be collected from the nursing colleagues, and we compare the two data points, like baseline data we collect, and then we collect the outcomes which come from the change ideas which have taken place. So here also the same records actually help us. So this is an example of run chart. I will not go into the details of the rules of run chart, but this is a run chart in which what we do day wise. As I said, the quality improvement projects don't run into years and months. Actually, we can see the changes in few days or a few weeks, depending on the number of patients which we are testing. So each point is called a data point, and we can see the trend or a shift. We have bring about a change, we have brought about a change, and we see that how the measures are changing, the data is changing. KMC, suppose the KMC hours, the mean duration of KMC hours. We can just at a glance see that how the change has brought about the change in the data. The change idea has brought about the change in the data. like example I wanted to give, maternal breastfeeding practices amongst the babies in NICU from our unit. See, so we started at a baseline rate of say to 8%, 26%. Then it increased after we brought about a change idea like counseling of the mother and making the baby room in with the mother. So these can bring about a change. Then again it dips. We see there is a dip. What must have happened? So these are all actually visual impressions of the change ideas, which actually can indicate how the change is bringing about a change in the data or effect of the change idea. So how do we identify a change change ideas that work? This is called a PDSA cycle: plan, do, study, and act. The aim which we have planned, we actually implement the change, one change at a time, and then we study that change. As I showed you in the run chart. The run chart was just a part, one part of the analysis or one depiction. There can be number of depictions like bar graphs, histograms, simple statistics can be represented, and we can study the effect of the change which we have brought, and then how do we act upon that. Okay, so this is a PDSA cycle in which we actually identify which change has brought about the effect of improvement or basically reduction of harmful practices in the unit. So these were the 6 or 7 steps broadly in simple language that how the QI can work. Now I'll just take you through 2 or 3 examples of how these projects were taken and how the nursing colleagues and the doctors came together to improve certain things in the unit. So this was one of the projects which we did at AIIMS to improve the thermal care bundle in preterm babies. And you see the context and the situation was AIIMS delivery room and the NICU. And this was the team, and you see there was equal number of sisters who were there along with the doctors, the resident doctors, and the faculty members. So you see, without nursing colleagues and without the frontline workers, it's actually impossible to bring about the change. So what we did, we used to measure that how the thermal bundle in the delivery room is actually functioning in the preterm babies. So we took the baseline data. The baseline data was it was much below what we expected. The normal temperature is 36 to 36.5. So we see that the median was 35.5 sort of thing. So we brought about the change, and we brought about the change that we introduced the plastic bags. Even after introducing of the plastic bags, we saw that there was not much change in the median temperature which was happening. We did not see any upward trend that the temperature was rising. Okay, so babies were still cold in the delivery room. We introduced these cling wraps, and what actually worked in the change 2 or idea 2, we had to include the delivery room and the labor room nurses and the NICU nurses. So when they came about as a team, the sisters and the doctors, including the obstetricians, obstetric nurses and the neonatology nurses, we could see that there was significant improvement in the temperature of the babies who were being received in the delivery room, who were being managed in the delivery room during resuscitation, and it improved to 36.5 to 37 degrees Celsius. So this was an example, and we saw it live, that if you do not involve them and if you do not work as a team, it is very, very difficult to bring about even a simple change. It looks very simple that improve the temperature of the babies. But actually it took a lot of cycles and lot of change ideas, lot of improvement ideas, involvement of the frontline workers, repeated teamwork and repeated huddles, repeated trainings, repeated information. All these are required actually. So we cannot undermine the role of any of the frontline workers in the units. From AIIMS, I moved to Vardhaman Mahavir Medical College and Safdarjung Hospital, which was a totally different hospital. It was a large 2,900 bedded hospital, and it has 3 neonatal intensive care units and spread over 3 floors. So here also we actually thought that we needed to reduce the hypothermia in babies, low birth weight babies. So here I myself was on rounds, and what triggered the change idea in this hospital was the on-duty nursing officer actually pointed out to us on rounds that babies for the last 3-4 days are coming cold when they are receiving from the birthing area into the NICU. So we did this root cause analysis, which is the one of the core component of fishbone analysis, core component of the quality improvement, where we actually look upon to find the cause we should, instead of blaming and shaming, we actually have to look why did it happen, why is it happen. So what we did, we actually collected the baseline, like what happened in the last 3 days, what was the baseline temperature at which the babies were being received, and what did we do as a change idea. We visited the birthing areas, we checked the equipment, whether the delivery room equipments were working, we checked the records. Again, the records are with whom? Records are with the labor room and the NICU nurses. So we went that, and we went ahead and did that, and we saw that the radiant warmer was actually not functional for the last 2-3 shifts, and it was brought again to the notice of by the nursing staff only. And this was the report book which we saw, and we saw that the admission temperature column actually was not there, and there was admission temperature was not being recorded. So again, as a team, we got along. We called the residents and the doctors and the nurses both are sitting, and we trained them. We told them the importance of the functioning of radiant warmer, and also the environment, how to resuscitate and how to keep the delivery room warm. So these are the simple things, and the nurses and the doctors, we all sat together and we looked at the standard guidelines and the videos. We trained them again because some of the staff was new. And we involved the stakeholders and the policy makers, our unit in charges, the medical superintendents, and the mothers also. So basically, we found that once we involved everyone, it was easier to bring about a change. And this I could feel actually as a real life, and in my own experience, I could feel that we cannot actually go ahead without involving everybody who is working frontline. Now, short-term changes are okay, but how to sustain that? The most important step of any quality improvement project is sustenance. Acha lagta hai when it actually 3-4 months may it improves, then again it can fall down if you do not actually follow up with the data. So again, for that also, everybody needs to be involved. And we actually presented this, that what are the sustenance tips in the at AIIMS. When we started in 2015, there were 4 projects which we started, and all these 4 projects actually were sustained over the next 2 years, 3 years, which included increasing the express breast milk, kangaroo mother care increase, reduction of breakage of the radiant warmer temperature probes, reduction of the alarms in multi-para monitors. So with the team, and till today, we actually are working in collaboration with them, because this teamwork and this goodwill and the team which you build, it actually goes along with you wherever you go, and it actually gives a lot of satisfaction. And not to forget the role of nursing colleagues in publications from the quality improvement projects. And we could actually publish few of them, including quality of discharge counseling and reducing unnecessary follow-up visits, improving breastfeeding rates, even from Southern India and all over India. We have seen that nurses are actually as authors of quality improvement projects in various publications. So these are just the examples that we can do it as a team, and we should do it to improve the quality of healthcare. I would like to end with the theme of this year's International Nursing Days theme, that nurses are indeed a voice to lead, and we should invest in nursing and respect each and everyone's rights, not only the nurses, the doctors and the nurses both. Thank you so much.
Thank you, Dr. Pratima, for a nice lucid presentation on quality improvement methodology. So basically, what she has tried to tell us is what is quality improvement. Quality improvement is to be done by whom? Who are those people who are going to work on quality, improving the quality of care in our hospital? So basically, quality improvement is to be done by everybody. ये सबका job है. ये सिर्फ डॉक्टरों का या नर्सेस का job नहीं है. सबका है. So doctors, nurses, paramedics, administratives, the in charges, payers, policy makers, and community. Don't forget community. So all these stakeholders come together and try to improve the quality of healthcare. And while doing that, you can use the methodology, the model for improvement or the point of care quality improvement. So 3 important सवाल जो है हमें पूछने पड़ेंगे अपने आप से, अपने टीम से. What are we trying to achieve? हम क्या करना चाह रहे हैं? How will we know that change is an improvement? क्या change करने के बाद हमें कैसा पता चलेगा हम improve हो रहे हैं या नहीं हो रहे? And what changes will lead to improvement? क्या changes हम करेंगे जो हमें improvement दिलवाएंगे? These are the 3 basic questions we need to answer if we want to perform as a reliable unit in delivering the quality healthcare outcomes. Very important thing. So I will just share my screen here. So, 150-200 साल पहले भी हमें ये मैसेज दिया था फ्लोरेंस नाइटिंगेल ने, है ना? So that is why we now celebrate the Nurses Week between May 6 to 12, and 12th is the birthday of Florence Nightingale. And we all know that she is recognized for transforming nursing from a service to a profession. But what very few people know is that she is also to be recognized as one of the first safety and quality leaders in healthcare. Okay. So she recognized that what we now call a total system safety. She was the first to recognize that everyone in healthcare system contributes to quality and safety. She asserted that the entire healthcare team should be accountable for safe and high quality care. And she used the methodology at that time, the tools. So she used diagrams to help understand problems. She set aims, she assigned metrics for the improvement. She had the measurement for improvement at that time also. And she also developed and implemented action plans to improve the sanitary conditions. So she made hand washing, bathing, and principles of such as mandatory. And she demonstrated people that it improves the outcome by documenting reduction in hospital death rate by 2/3 during the war. Okay. Now, nowadays, what we say, we should ask people what matters to them first. So she was probably the first person who addressed what matters to the patients. She helped set standard for compassionate, patient-centered care. And she championed many innovations which are designed to treat patients with dignity and respect. Some of the examples include creating kitchen to make appetizing meals, establishing a library or a classroom for entertainment and intellectual stimulation, and starting a laundry for clean sheets. These were some of the examples of the innovations she carried out in those times. She also introduced the world to the culture of safety. She noted that how very little can be done under the spirit of fear. Fear se kuch kaam nahi hoga. We need to provide the environment of psychological safety to our staff. And she recognized that this very fact, which is now actually buzzword in quality improvement, psychological safety in healthcare. She recognizes it almost 150 to 100 years back. And by showing exemplary courage in speaking up and challenging the traditional medical authority, she was instrumental in advancing collaborative and high quality care. And at that time, she defined the necessary elements of cultures of safety. She knew that nurses are the high impact leaders in healthcare. So she set the vision for nursing as a profession and established principles and priorities for nursing education. And she was the early proponent of evidence-based care. She recognized the privilege of nurses to view, understand, and transform healthcare system. And she was committed to interprofessional learning system to improve the healthcare. So she knew that we need to design learning system if we want to improve the healthcare. And she believed that hospital leaders must ensure patient and workforce safety as core values. So imagine what is now the world is identifying as very important if we want to improve the quality of healthcare. She knew it is 150 years back. She also knew the importance of data for improvement. So she called it the statistics as the most important science in the world. And she broke new ground with her use of data to understand current state, evaluate priorities, and assess the progress in improving patient outcomes. So she used root cause analysis at that time to reveal that British soldiers were more likely to die because of typhoid, cholera, and dysentery than injuries sustained in the battle. So imagine her vision. And that is why she is called a lady with the lamp. So even after 200 years after birth, This lady with the lamp continues to light our path forward and inspires nurses and all healthcare professionals to continuously improve the care, never settling for the status quo. This was the impact she had on the quality of healthcare. And this is a message to all of our frontline workers, that is the nurses, that they should bring problems to the healthcare leaders. They should be actively involved in identifying the problem, which is the most important step in quality improvement, because identification of problem itself is a big problem in our setups, especially in Indian context. So, and it is our job as leaders in healthcare to provide the psychologically safe environment if we want to improve the quality of healthcare. So this was a wonderful, great talk by Dr. Pratima. She introduced us to the theory of quality improvement, the tools of quality improvement. Friends, tools also give result, but to sustain what she has told us is to sustain the results achieved by using the tools, we need to change our behavior, because every system is designed to deliver the same results year after year, and we need to redesign our systems if we want to improve. So thank you very much for this nice presentation. And thank you, Ashish, for giving me this opportunity. Thank you all the office bearer to moderate this session. Thank you very much.
So yes, thank you, Dr. Kedar, for your expert comments and for summarizing the talk on qualitative improvement. As you rightly put, yes, Florence Nightingale, I think, started the quality improvement project, and that's what I think Dr. Pratima has also put it all together very well. I mean, how to conduct a quality improvement project. And I think quality improvement project will bring a paradigm shift in your practice in unit. So I think it's a great inspiration and motivation for all the units to at least start at least one quality improvement project in the unit, so that it could be anything regarding temperature, regarding sepsis, but I think it will enable them to help, I mean, progress forward and mitigate a lot of problems which they have in the unit. And I'm sure the nurses are going to be the key figures in this quality improvement project. So thank you, Dr. Pratima, and thank you, Dr. Atul Londe sir, for his presentation on analysis of arterial blood gas. I think that was also he has shown quite a number of videos to do how to do arterial blood gas, to do how crucial it is to do Allen's test, and how you can analyze the arterial blood gas. So he has given very nice fine points to us. So I thank you all the viewers for attending this program. And for our next program will be on 27th of May on a Friday, 4 to 5 p.m. And it will be on, we are again taken two important topics. One is assisting intubation, so which is commonly performed in all the NICUs, and care of a ventilatory baby. So once you have a neonate on a ventilator, what care needs to be taken. So thank you very much, everyone. And I hope you had a wonderful session. And I also want you to continue celebrating this Nurses Week to the fullest extent. Thank you so much. So with this, I'll close the session now. Thank you all.